Thank you for participating in our past CME programs. We are honored that you have chosen our programs to attend. And because of the current situation, we now believe that more than ever, we have a duty to perform, to fulfill our mission for all our learners, and to help them to develop the skills and confidence they need to take care of all their patients during these trying times. I developed this short talk on COVID-19 and diabetes to help many people answer the questions that many of our patients are addressing to them, namely, if I have diabetes, what are my risks for getting COVID? What are my risks for getting severe COVID, and what should I do to prevent it? This will be discussed in more detail at our upcoming programs, but what I'm going to do now is discuss some of the clinical characteristics and risk factors for mortality of COVID-19 in people with diabetes. I'm going to discuss the approaches that we recommend to prevent COVID-19, and I'm going to discuss management of diabetes if COVID-19 is in fact acquired. This is a slide taken from a recent review looking at people with diabetes, demonstrating that they are more likely to have severe COVID than non-severe COVID-19 infection. This is a meta-analysis of a number of studies that you can see here, showing in the darker lines a lower prevalence of severe COVID in people without diabetes as compared to diabetes, and also the fact that people are more likely to have severe COVID, shown in the lighter lines, if they do have diabetes. This in fact translates to a meta-analysis that also shows mortality rates. Non-survivors there's a higher prevalence of so-called non-survivors than survivors in people with diabetes who acquire COVID infection. In fact, one of the original sites of COVID, as you know, was in China. And this is a study that was retrospectively done to look at the clinical characteristics and the risk factors for mortality of COVID-19 in people with diabetes in Wuhan. And this was 2 centers in Wuhan that were reviewed. There was clearly, in this case, worse outcomes for people who had diabetes if they acquired COVID than those who didn't. You can see the survival probability was significantly lower in the red line than in people with diabetes than who didn't have diabetes, which is the survival probability shown in the black line. Furthermore, a higher percentage of people with diabetes were admitted to the ICU, 17.6% versus 7.8% without diabetes. And the fatality rate overall was almost double in people with diabetes. It was 20.3% as compared to 10.5% in people who didn't have diabetes. Furthermore, in this study, the people with diabetes who did not survive tended to be older, they tended to be male, and they were more likely to have other comorbidities like hypertension and cardiovascular disease. In fact, age of 70 or higher and hypertension were regarded as independent risk factors for mortality. The summary of this study is shown here, and I'll just read it to you. The findings of our study suggested that COVID-19 patients with diabetes had far worse outcomes compared to age and sex age-matched controls, people without diabetes. Diabetes itself was not independently associated with in-hospital death, while hypertension, cardiovascular disease, and chronic pulmonary disease played more important roles in contributing to the mortality of COVID-19 patients. In-hospital death amongst COVID-19 patients with diabetes was associated with hypertension and advanced age, whereas only older age was independently associated with death amongst matched patients without diabetes. Having said that, there's a subsequent study published in the journal Cell Metabolism that showed that people with well-controlled glucose had lower mortality rates than those with higher glucose levels. These are people with diabetes showing that if their glucose was less than 10 millimoles or 180 milligram per deciliter in hospital, their survival rate was 98.9%, as compared to those people who had a death rate of 11% if they had poorly controlled blood glucoses being greater than 180 milligrams per deciliter. This is a significant difference in survival rates between the well-controlled versus the less well-controlled group of people. People with type 2 diabetes and COVID-19 in this study were also more likely to require intensive hospital treatment. People with type 2 diabetes had a higher risk of all-cause mortality and morbidity, 7.8% versus 2.7%. But well-controlled diabetes prior to admission was associated with a lower mortality and a lower morbidity. There's another study, interestingly, published online just last month, showing that the fasting glucose in itself at the time of admission is an independent risk factor and predictor for mortality in people with COVID-19 who didn't have a previous history of diabetes. As you well know, a number of people have been admitted with COVID-19 and coexistent hyperglycemia who were not known to have diabetes in the past. This study looked at that and showed that if your admission glucose was under 110 milligrams per deciliter, your cumulative mortality that's shown in the red line was significantly lower than if your admission glucose was between 110 and 124 milligrams per deciliter, shown in the green line, as compared to more than 126 milligrams per deciliter, shown in the blue line. Now, in France, there was a large study called the Coronado study, which is COVID and diabetes study, looking at the phenotypic characteristics and the prognosis of inpatients with COVID-19 and diabetes. And they came up with some interesting observations. In people with diabetes who are hospitalized with COVID-19, the BMI, but not long-term glucose control, is associated with tracheal intubation and or death within the time frame of the study, which was 7 days. So if you look at the left-hand side of the slide, BMI over here, the top left-hand side, shows that with increasing BMI, there is an increasing mortality rate. As compared to hemoglobin A1C, the bottom left-hand side of the slide, there was no significant correlation between mortality and A1C. You can see the line is flat. And on the right-hand side of the slide, the admission plasma glucose correlated with an increasing risk of this primary endpoint, which was tracheal intubation and or death within 1 week. So once again, we see that the admission glucose plays a role, BMI plays a role, but prior A1C did not seem to affect mortality. Overall, this group of individuals had a 10.6% mortality rate. Factors not associated with increasing COVID severity were, as I said, A1C, and in addition to that, use of medications including the renin-angiotensin system inhibitors or DPP-4 inhibitors. Once again, independent risk factors for early death included age, the presence of micro or macrovascular complications, and also the presence of obstructive sleep apnea. So what should we tell our patients with diabetes? First of all, prevent COVID whenever possible. Stay home if you can, wash your hands often, clean the surfaces, avoid touching your face, and wear a mask when in public. Second of all, optimize glycemic control. Use this as an opportunity to maintain a better diet, continue to exercise regularly, check your glucose levels frequently at home. Get enough sleep, maintain your mental health, continue to take all of your medications, and take advantage of telemedicine to maintain connections with your healthcare providers. What should our patients do if they become infected with COVID-19? Well, we look upon this three severities of infection in many ways. If this infection is mild and asymptomatic, we tell our patients to stay home, continue their usual medications, increase their frequency of glucose monitoring to make sure they maintain good control. If the patients are symptomatic, but not severe enough to require hospitalization, we would tell them to discontinue certain medications like SGLT2 inhibitors, which may increase the risk for ketoacidosis. If there's a significant nausea or a GI component to the COVID-19, they may need to stop their GLP-1 receptor agonists. Patients may need to increase their doses of insulin. Just like in any other infection, the infection and the stress of the infection increases insulin requirements, even if patients are not necessarily eating more. Check blood sugars more often, check ketones if appropriate, and maintain hydration. In the case of severe infection, hospitalization is likely, and intensive care unit is going to be more likely if you have diabetes. Certainly, once patients are admitted to hospital, it is highly likely they will require insulin to control glucose, and in the setting of an ICU, it's more likely to be IV insulin infusions. People should stop metformin, especially if they are severely ill with hemodynamic instability and/or hypoxemia. SGLT2 inhibitors should be stopped. GLP-1 receptor agonists should be stopped in severely ill patients. And if people are not eating regular meals or there is a risk of hypoglycemia, sulfonylureas should also be stopped. Thiazolidinedione should be stopped in severely ill people with hemodynamic instability and/or cardiac or liver dysfunction. Generally speaking, ACE inhibitors and angiotensin receptor blockers are continued unless there's a contraindication. Aspirin is generally continued for secondary prevention of atherosclerotic cardiovascular disease unless that's contraindicated. An individualized decision needs to be made about the use of statins. So in summary, people with diabetes are not at increased risk for acquiring COVID-19 infection, but they are at increased risk for developing more severe infection in general. Mortality rates are definitely lower in people with better glucose control, particularly during hospitalization. As we saw in a previous study, fasting glucose, even in people without diabetes, is a good predictor of outcome. The presence of other risk factors, hypertension, coronary artery disease, obesity, independently predict less favorable outcomes. There is limited data on people with type 1 diabetes, but it seems that younger, well-controlled people are probably not at increased risk for severe infection, but are at increased risk for the development of ketoacidosis. It's important for people with diabetes to use this period of time as an opportunity to maintain or improve glycemic control by maintaining or improving all aspects of diabetes self-care during this pandemic, and to be vigilant about taking precautions to prevent COVID-19. Take advantage of telehealth where appropriate. If COVID-19 infection does occur, increase glucose monitoring, stop certain medications if appropriate, maintain hydration, maintain good control. And if people with COVID-19 require hospitalization, they certainly are more likely to require ICU admission. Thank you so much for participating in this lecture. Thank you for listening. I hope it's been of some value to you. And I look forward to live streaming courses later in the year and to your participation in those courses. Thank you so much.